Hello everyone and welcome to the Art of Medicine. I'm Dr. Motahare and in today's video we'll talk about Polycystic Ovary Syndrome, a very common condition that affects a lot of women around the world. We will cover what it is, how it's diagnosed, what are the symptoms, and what are the most effective treatments options available now. So grab your notebook or just sit back and listen. Let's explore PCOS together. So, what is polycystic ovary syndrome, PCOS? It is one of the most common endocrine metabolic disorder affecting reproductive age women around the world. It involves a combination of hormonal imbalance, primary excess androgens, and ovarian dysfunction, leading to symptoms like irregular menstrual cycles, infertility, and metabolic complications. It also affects psychological health. This is a complex condition, impacts reproductive, metabolic, and psychological domains, and requires a multidisciplinary approach for management. PCOS symptoms usually start around adolescence, often soon after menarche, but the diagnosis may be delayed due to variability in the presentation. The prevalence estimated to be about 8 to 13% depending on the population studies and the diagnostic criteria that they used. The most common used diagnostic criteria is Rotterdam criteria that we will talk about it later. This makes PCOS a significant public health issue due to its high prevalence and also long-term health consequences. PCOS manifests through reproductive symptoms such as irregular or absence of menstrual cycles, or androgen excess causing physical signs like hirsutism, male pattern hair loss, acne, or metabolic syndrome, which include overweight or obesity, dyslipidemia, and insulin resistance, that all increase the risk of cardiovascular disease. Additionally, women with PCOS may experience mood disorders and also sleep apnea if they are obese. The pathophysiology of PCOS is multifactorial. It means that a combination of genetics, environmental, and epigenetics factors all works together in order to disrupt normal ovarian function. Increased androgen level is the hallmark of this problem. Insulin resistance and compensatory hyperinsulinemia exacerbate androgen production and also decrease another protein, which is sex hormone binding globulin, that all lead to increase the free androgen level. Besides that, adipose tissue dysfunction contributes through inflammatory pathways that worsen insulin resistance and create a vicious cycle. Lab tests commonly show elevated total and free levels of testosterone and other related hormones. LH is often relatively elevated compared to FSH, though it's not diagnostic alone, but it's a clue. Sex hormone binding globulin, which binds to androgen, will be decreased due to hyperinsulinemia, and that can lead to higher level of free androgen. All just contribute to the symptoms that we observe in this problem. Obesity frequently coexists with PCOS, but it's not universal. It means that not all women with PCOS are obese. What are the reasons? One of them is insulin resistance that promote increased fat production and decreased fat breakdown. Adipocytes, that means the adipose tissue cells, may work dysfunctionally, releasing some inflammatory materials that favor central fat accumulation. Genetics and epigenetics factors may predispose some individuals both to PCOS and obesity. Importantly, even modest weight loss, 5 to 10% of body weight, can significantly improve these symptoms, reproductive symptoms, and metabolic outcome. One of the really bothering symptoms of PCOS is hirsutism, which is excessive male pattern hair growth in areas that are not for women, like in the face, on the chest, or on the back. That is the result of elevated circulating androgens. And also increased local skin conversion of that testosterone to more potent form by an enzyme that is located there. Hair follicles may also have increased sensitivity to that androgen that leads to male pattern hair loss here, like male pattern hair loss. Genetics and ethnic factors all influence the degree of this problem, and also clinical severity doesn't always perfectly correlate with the serum androgen level. It means that sometimes serum androgen level is very high, but this problem is not that much prominent. Otherwise, the serum androgen level is not too much high, but symptoms are very clear. In polycystic ovary syndrome, the ovarian follicles that are going to release some ovum for being a baby later stop growing at some points. So that several reasons that I told you, environmental, genetics, epigenetics. They don't release that ovum in a predictive manner. And also even they don't release anything at all. That can lead to sometimes infertility. This makes PCOS the most common cause of infertility that is related to ovary. Treatment focuses on restoring ovulation through lifestyle changes, pharmacological ovulation induction, and also assist reproductive technologies if needed. The most commonly used system for diagnosis of PCOS is Rotterdam criteria, which requires 2 out of 3 major criteria again. The first one is oligo or anovulation cycles. That means there is no menstrual period or irregular menstrual periods. Clinical or biochemical hyperandrogenism. Clinical, like all that symptoms that we talk about, like acne, hirsutism, hair loss, male pattern hair loss, or increased blood level of testosterone and or other androgen hormones. And finally, polycystic ovarian morphology on the ultrasound. It's crucial to rule out other causes of androgen excess, such as what? Such as thyroid disorder can lead to hyperandrogenism or hyperprolactemia or congenital adrenal hyperplasia or androgen secreting tumors. But we should be careful about adolescence. In the beginning of menarche, the menstrual periods are not regular. They are so irregular. This is part of normal puberty. If this pattern lasts for a long time, then we can suspect this problem. And also, if this pattern coexists with other things like obesity, like lots of acne or lots of hairs in the face, chest, back, or increased blood pressure, or dyslipidemia, diabetes type 2, if there are this combination, we will think about this problem more. But it's important to rule out other causes of hyperandrogenism. So first, we start with a complete history and also physical examination. Then maybe we should order some lab tests like serum testosterone, sex hormone binding globulin, hemoglobin A1C in order to find out about hyperinsulinemia and diabetes type 2 and a lipid profile. Oral glucose tolerance test is recommended if they are risk factor for diabetes type 2 or prior to pregnancy. It means that a PCOS lady wants to become pregnant, so before that we should do the glucose tolerance test. Additionally, some tests like 17-hydroxyprogesterone can help us to rule out some non-classic congenital adrenal hyperplasia. And finally, pelvic ultrasound can identify the polycystic ovarian morphology, but it is not mandatory if you have the other criteria, the other two criteria. Management of PCOS is based on the symptoms. We just trying hard to minimize the symptoms as much as possible and also reduce the long-term health risks. Life modifications with diet and exercise is the foundation of treatment of this problem, particularly in overweight or obese patients. Sometimes we use some kind of contraceptives like combined oral contraceptives to help regulate menses and reduce androgen level. Sometimes we need anti-androgen drugs. This is all depends on the patient situation. And also not just symptoms, patient situation, patient symptoms, patient will to be pregnant or not, she wants any contraceptive or not. All of these things are contributed to the doctor's decision to prescribe a medicine. For insulin resistance, we can use some metformin to improve the insulin resistance and also metabolic health. Sometimes we need some drugs to induce ovulation, and sometimes cosmetic treatments for excessive hairs, such as laser therapy, to help manage this problem, because sometimes it will be really bothering for a lady to look like that. To be honest, there is no known primary prevention for genetically predisposed PCOS. However, very soon, early lifestyle interventions can reduce obesity development and improve metabolic health and also reproductive outcomes. We should regularly screen for metabolic syndrome components such as central obesity, dyslipidemia, hypertension, diabetes type 2, and also we should screen for cardiovascular risk factors. Mental health and sleep disorders should be assessed and managed accordingly because they are higher in PCOS women. If we do not do anything for this problem, in the short to medium term, PCOS causes infertility, hirsutism, and psychological problems. In the long term, it can cause diabetes type 2, metabolic syndrome, and adverse pregnancy outcomes, such as gestational diabetes or hypertension. Lots of evidence just suggests that cardiovascular risk factors will be increased in this population. But the good news is effective long-term management with lifestyle and medical therapies can reduce all these complications. Thank you for spending your time today with me. and for being part of our growing community, The Art of Medicine with Dr. Motahare. If this video helped you understand PCOS better, please give it a like, subscribe to the channel, and share it with someone who needs that. And remember, medicine is not just about treating disease. It's about understanding people around us. Until next video, stay healthy, stay curious, and I'll see you in the next